and Neurology for the primary care physician. Tonight's speakers are Drs. Ben Szerlip, Gary Millard, Daniel Pap, and Martin Taylor. The speakers will answer questions following each of their presentations. Please type your questions into the Q&A box at the bottom of your screen. Our first speaker is a new surgeon to the practice, Dr. Ben Szerlip. Dr. Szerlip is a board-certified fellowship-trained orthopedic surgeon specializing in all aspects of the shoulder, including total and reverse shoulder replacements, arthroscopic rotator cuff repair, fracture care, sports medicine, as well as non-operative treatments. Tonight, Dr. Szerlip will be presenting on when to refer to a shoulder specialist. Dr. Szerlip?
Hello, thank you very much for having me. Let's see, I'm going to proceed to share the screen and start the PowerPoint. It's a pleasure to be back here in Ohio. I'm from Mount Vernon, so I've been practicing in Austin, Texas for the past 6 years. Very excited to be back with my family. If you have any questions, please type them out and I'll be happy to answer them after the PowerPoint. I think that's the most productive part for everyone. So I'm going to go over some common shoulder problems that everyone's going to see in the office and then how to manage that. Let's see here. I do have some disclosures. I'm a consultant and an educator for both Tornier and Integra. They produce shoulder systems, but this will not have any relevancy to the talk today. Some of my background, I trained and did shoulder fellowship in Houston, Texas with Dr. Edwards, and then also started or co-founded the Austin Shoulder Institute with Dr. Graham. And that's where I've been practicing for the past 6 years. So in general, this is a crash course on anatomy. Why do patients come in with shoulder pain? Some of the new technologies and advances we've done, and then what patients can expect with non-operative treatments and operative treatments. The crash course in anatomy, we'll try to get through all of this in 20 minutes, but the short version is that the ball and socket joint of the shoulder is not exactly like the hip. It's much less constrained, it allows more motion, but inherently it's more stable and is more predisposed to injure those soft tissues that act as a dynamic stabilizer and not just a static stabilizer like the bony architecture. Essentially here is kind of showing that it's a golf ball sitting on a golf tee. That's the analogy I use for my patients. And there you have it. The labrum, I'm sure you guys hear all the time or see this in MRIs. I have a torn labrum, I have an issue with my labrum. That is essentially the gasket or the liner around the socket joint. It helps to deepen and stabilize that joint, and it can be a degenerative tear as well. So as we get older, just like my hairline, as you can see, that can start to creep back or fray. So it's really a very common questions that patients have in primary care givers do too. So another picture on how it acts as a stabilizer in a bumper or a shock absorber. And that can be torn when the patient has instability or through degenerative tears as well. Another example here, the rotator cuff. You've probably all seen those as well. One of the more common injuries. There's 4 muscles to the rotator cuff. Those help stabilize as well as move the arm. We're going to kind of go through the common injuries, rotator cuff, arthritis, dislocations, AC joint injuries, fractures, biceps tearing. All of these are injuries that you've most likely seen in the office and ones that I see every day. Natural history, rotator cuff tears, 17 million tears a year. That's quite a bit. They are age related. So anybody over 75 years young is 50-50, they have a rotator cuff tear. Not all tears are symptomatic, and that's why there's 17 million around there walking around, not coming into our offices. The good news is that as tears, if they do progress, patients usually have more pain. So instead of MRIing everyone that walks into the office, we can say, hey, if they have more pain, if they're symptomatic, if they're losing function, then we get an MRI to evaluate that or diagnose the rotator cuff. Symptoms, night pain, weakness, loss of function, and they complain of commonly over the lateral deltoid right there. They say, hey, it's a dark, deep ache on the lateral aspect of their deltoid. MRI has been the gold standard in the United States for rotator cuff tear diagnosis, but in Europe and other parts of the world, ultrasound has been a really helpful and useful alternative in an experienced person's hands. And I will do ultrasound in the office just to confirm or give somebody an impression of if they have rotator cuff pathology. Some of the interesting things we'll cover are the location of the tear, the size, and the muscle atrophy. So who needs surgery, right? That is the big question we're here today for, and when to send to a specialist. But typically the people who are eligible or good candidates for surgery, they're usually younger, more active, and I define younger is patients under the age of 70, 75. They have acute traumatic tears. They're still relatively active. Fixable, we'll talk more about. And the symptoms are really interfering with their quality of life, and non-operative treatments are not helping them. But if a younger active patient, again, under 65, 70 years old, is having a full thickness cuff tear, that's prophylactically recommended that we repair the tear so it doesn't continue to progress, retract, and then atrophy. So what are the factors that go into whether a patient will do well and whether the tendon will heal or not? Acute versus chronic tears, I tell my patients to think of it like a plant being pulled out of the ground. If you let it sit outside too long and you don't replant it, it will have long-term effects and decrease your chances that the tendon will heal. Tear size. So if there's multiple tendons involved or the tendon's completely pulled back past the socket, that can be a detrimental factor for healing. Muscle atrophy is essentially the replacing muscle with fat. Think of like a lean piece of venison or steak and then replacing that with a piece of bacon or a wet piece of toilet paper. They're not equal. And it's really important to educate the patient on whether they have good viable tissue to repair or that they have completely degenerated atrophied tissue. Age, as we all know, chronologic and physiologic. I tend to lean more towards physiologic with my patients. Is arthritis present? That means if you repair the rotator cuff and they still have arthritis, they're not going to be that happy with the surgery and their recovery. Obviously, medical comorbidities, some of them smoking, diabetes, kidney issues, autoimmune disease like rheumatoid, those can all play a role in whether we get that tendon to heal as well. And this is kind of what I alluded to. It's these rotator cuff tears are not all the same. They're really comparing apples to oranges, and understanding some of those factors we just discussed in the last slide will help you and help us determine what's the right way to go for the patient. This is an example on the left side of your screen with a full thickness rotator cuff tear. I'm going to go here with the arrow. This is where the tendon is right now. This is where it should be over here on the footprint. This is the supraspinatus muscle. This is the glenoid. This is the humeral head. As you can kind of see, that humeral head wants to kind of go up without that humeral head depressor, the supraspinatus on there. So our job is to take the tendon and then pull it back or tie it down to this footprint and get it to heal. I tell the patients it's like the roots trying to take effect in that ground, and that can be a long-term process, 3 to 6 months before they can lift anything heavy overhead. But they do get good results, and it's also, again, prophylactic or preventative, because if this cuff tear should progress and atrophy, the patient's got a very poor function, very poor motion and increased pain. So good results with the rotator cuff, 95% pain relief. That's excellent. But the small and medium tears have a less likelihood to re-tear. And then the large you get with atrophy is creeping up into the 20, 30, 40% range. So we have to educate patients on that. And the good news, however, even if a patient does have a large tear and they have some atrophy, they tend to get better function and pain relief, even if the tendon doesn't completely heal, because you repaired part of it and gave them more coverage or function. The arthroscopic advances. So the new anchors are not metal anymore, so there's not metal floating in the joint. They're bioabsorbable. They absorb over a couple of years. The sutures have become much better. They have a higher profile. They're more they're strong. So if anything does fail in the newer surgeries, it's usually the rotator cuff tendon itself and not the suture or the anchors. That is tended to be the weak link. There's double row fixations. They're so basically increasing the biomechanical advantages behind these repairs. And surgeon experience, the fellowship behind the training has been key or instrumental. Essentially the 10,000 hour rule, if you ever heard about that. But that's why my love and my passion is to do shoulder surgery. And we've done over 1,000 of these rotator cuff repairs and published on those results. So shoulder arthritis is a different topic. So we're going to switch gears. Quite a few Americans have dealt with that. And I'm sure you have many, many patients in your practice with joint replacements, most likely hip or knee, but shoulder is the third most prevalent and rising every year in the number of replacements that have gone in. So here at the bottom, you can kind of see that the hips and knees are over 1 million replacements a year. Shoulder is quickly climbing because the technology is improving. And so patients have more options, and not just, hey, your shoulder hurts, you'll never get overhead again. You're going to have to learn how to deal with it. But we've probably seen these x-rays. The cartilage is bone on bone. It starts to erode the socket. And here, back to the preface of this talk, is when do I send to a specialist, or when do I catch this? Because if we make mistakes, we don't get x-rays in the office, we'll kind of blow things off, and these patients are having a lot of pain. But it's typically they have pain at night, they're losing motion, they sometimes lose strength, and then getting the x-rays in the office or knowing when to get the physician. In general, I tell patients, or I tell most primary care docs, that if they're having persistent pain and they're having pain that influences their occupation or their habits or habits or hobbies, and they're not getting in better with just giving it time or an injection, I would send to a specialist to have it evaluated and see if we can't give any insight or additional treatment. And I'm happy to also share my cell phone. And if you ever want to call me, text me about x-rays or about a patient, Heather would be happy to pass along my contact information, because I think we are all able to treat the patients better that way. 3 goals for treatment. They're very simple: pain control, optimizing function, and then educating patients about their outcomes and choices. Again, we've all used these for temporary relief, anti-inflammatories, injections. I typically don't use sleep aids, but those are a possibility. Physical therapy is another excellent form of non-operative treatment that I've had good success with my patients. And I think it's very important to surgeons to let their patients and their referrals know that they don't just always recommend surgery. So what does make somebody a good candidate? Once again, I mentioned this before, but if the pain bothers them every day, if the pain is affecting their job or the hobbies that they love, if the pain is affecting their sleep or their mood, and they've tried other non-operative modalities that we discussed. These are some of the things that are unique replacements. So if a proximal humerus fracture or broken bone, it happens in an older patient, a shoulder replacement called a reverse has been very helpful to restore their function and relieve their pain. And that's just happened probably more so in the past 5 to 10 years. And we're actually doing a research project on that now, and it's showing very promising results. Some of the newer interesting technology, these are some of our patients here, but we're using on the total shoulder replacements much less metal, so it preserves the patient's bone, it preserves their native anatomy, and for these younger patients, it's been really helpful. And if they ever do need another replacement 15 to 20 years down the road, that can be done much more simply and easier. And with the new outcomes and some of the new data that we believe these shoulder replacements should last a patient 15 to 20 years, which has been getting better. So here you see one without a stem, and here you see one with a stem, and they've both done well. The reverse replacement, I'm sure you've seen or heard of, but these are typically used in patients without a rotator cuff and with shoulder arthritis. So these reverse replacements have been an excellent way to treat some of these patients who are usually over 60, 65, have rotator cuff pathology that cannot be repaired, like we mentioned before, and also have arthritis. But these patients also do not have restrictions. They're lifting weights, they're playing tennis, they're swimming. So it's nice to keep them active and keep them happy. This is another thing I thought I'd share. Some of the technologies allowed us to create a 3-dimensional model and then simulate the patient's surgery before we ever go into the operating room. We can now order specialized custom pieces and parts. And I do this for most of my patients. I'll bring them into the office. I'll show them these, templates, and they can even play around with them. We can adjust the size. And I think more importantly, they give you a predictor on the patient's function and range of motion, as I'll show here. I'll kind of advance the video, but it'll actually replay and then help you determine on what size, location, and part is going to give the patient the best motion and the best outcome. So I think it's been really helpful for both the surgeon and the patient. Okay, we'll stop that. So in general, we found that rotator cuff repairs, even if they don't completely heal, have shown to give patients benefits in terms of, decreased pain and improved function. And then shoulder replacements have also been very successful. And again, that number is climbing with the hip and knee every year. So over 60,000 replacements are performed in the US. And so I think that's going to be a more common thing that everyone sees in their practices, in their patients. I just wanted to say thank you so much. And then I'm going to go to the screen and see if we have any questions that came up. Heather, I'm going to tap on you to see if there's a screen where there's any questions.
Yes, there is one question from Dr. Berta. What happens if the patient has a torn deltoid muscles due to lifting weights and now shoulder is frozen?
Sure. The torn deltoid is quite uncommon. You can have particular fibers of the deltoid muscle torn, but it's a very, very large muscle with an extremely large footprint. So it's over 6 or 7 centimeters. Think of like a torn gluteus. There's a lot of muscles, so they don't typically need to be repaired, but the frozen shoulder thing is a very common and problematic injury, and that is a different animal. So frozen shoulder, it happens to 2% of the population for reasons we don't know. It does get better without surgery, but it can take up to a year. It's more prevalent in people with diabetes or thyroid issues or other endocrine issues. And we typically treat that with time. It can be intra-articular steroid injections and physical therapy to get the patient going. But excellent question on frozen shoulder, very common problem. Is there any other questions, Heather? Or otherwise I'll let everyone keep moving.
So how long is the recovery time for a reverse total shoulder replacement?
Yeah, great question. So it's actually, since I do both, I get to see patients in their recovery. The reverse patients actually get better quicker than the rotator cuff repair. And the simple way to understand that is that the rotator cuff, if you're 65 years old, that you have to depend on 65-year-old tissue to heal back down to the bone, as I showed in that picture. With the reverse, you do not need to depend on the rotator cuff to heal. And so the patient gains that stability and range of motion through the joint replacement, which is basically fixed into the bone at time 0 or the time of the surgery. So their recovery in general, they can play golf, they can swim, they can play tennis in about 3 months. And I usually hold the rotator cuff patients. They can't really do all of those things effectively until about 6 months.
Is there anything that you don't let your reverse totals do once they're released?
Actually, there are no restrictions at this point in time. Again, so the reverse replacement was, popularized in the 1970s and actually only approved in America, in the US, by the FDA around 2004. So it's been around for 15 years or so. And the technology's gotten so much better with the angles and the fixation and some of the other advancements that they can really do anything they want. Whereas 10 years ago, there used to be a lot of restrictions, a higher complication rate. And now the patients, again, I have a guy who's a bodybuilder. He can bench, 300 pounds, mostly though golfers, tennis players, swimmers, bikers. I can't say that the company probably does not advertise that somebody benched 300 pounds, but still it's great to see patients get active again. And I think that's what all of us want.
That's great. Are there any, oh, here's one. You're ordering a first set of x-rays. Which views do I order? Say 60-year-old back second visit.
Yeah, no, actually, if the primary care is ordering x-rays, I always you have to get at least 2 views. That's critical to have probably an orthogonal or a 90-degree angle. But I typically order 3 to 4 views. And 3 is standard, but a Grashy view, which will get an on-face view of the socket, then a Y view, and then an axillary. The axillary is very helpful. Now, if the patient has an injury, and they have a tough time determining whether the patient has a dislocated shoulder, something called a valpoaxillary, and it's VALPEAU. And anybody can Google that on their phone. And that's an excellent way to get an axillary view of the patient, even if they can't move their arm. That'll be so helpful to determine if the shoulder is actually dislocated, because it's very difficult to tell if it's just in the AP view or the gray sheet. Great question.
Do we have any additional questions? Thank you, Dr. Szerlip.
Oh, thank you so much for having me, Heather.
Our next speaker is Dr. Gary Millard. Dr. Millard is a board-certified fellowship-trained orthopedic hand surgeon specializing in hand and upper extremity care and surgery. Dr. Millard is speaking on carpal tunnel syndrome. Dr. Millard? Dr. Millard, you're muted. You need to unmute yourself. Dr. Millard, you're muted.
All right, I'm back. I'm sorry.
There we go.
Wasn't that smart at it, so.
That's okay.
All righty, and I'm back. So what we're going to be talking about today is carpal tunnel syndrome. By the way, are you able to see my screen right now?
Not yet. You need to share your screen. The green button at the bottom.
I just did that and it's not letting me do that for some reason. All right.
There we go.
Now am I here?
You're there. Yes.
All right. Sorry about that. All right. So yes, today we're going to be talking a little bit about carpal tunnel syndrome. Obviously, it's something very common that everybody sees in their office. What we're going to talk about a little bit is just how to evaluate the patient clinically and how to treat it, and basically when to look at doing surgery or not. So we're going to look at a little bit the definition, epidemiology, etiology of carpal tunnel, as well as some of the clinical features, the exam, a little bit of anatomy, some diagnostics, our differential diagnosis, and our treatment options. So first of all, carpal tunnel is the most common focal peripheral neuropathy in the body. It results from compression of the median nerve at the wrist. When we look at why, basically we're looking at the anatomy of the carpal tunnel. So when you look at the carpal tunnel, if you look at the diagram on the right, it is a very limited space that you basically have 9 tendons and 1 nerve running through. It's surrounded by bone. The only soft tissue restraint on it is the transverse carpal ligament. So again, that's a very small space with a lot of structures running through it. Again, the median nerve does supply sensation to classically the volar aspect of the thumb, the index, middle finger, and half of the ring finger. And that is where you would expect patients to complain of some symptoms from. As far as the epidemiology, it affects about 3% of adult Americans. It is 3 times more common in females than males. It does have a higher prevalence in people who perform repetitive wrist activities, particularly people working on computers, if they're working in production lines, if they're doing repetitive motions, that tends to be more associated with it. Unfortunately, it's a little difficult to prove direct relationships between them when it comes to workers' comp issues, but it is highly related. Apart from age and sex, there are a number of causes and contributing factors towards carpal tunnel. A number of them are very rare. as you look down the left, there can be some of the anatomy like abnormal tendons, some cysts, a thrombosed artery, infectious diseases that are not that common. Again, inflammatory conditions, these tend to be a little more common, specifically talking about rheumatoid, gout, or pseudoarthritis. Diabetes, looking down the right-hand side, and hypothyroidism or hypothyroidism are very common causes, as are the increased canal volume, including congestive heart failure, edema, obesity, and pregnancy. Basically, when a patient presents to you with carpal tunnel, they're going to complain of pain on the volar aspect of the wrist. They're going to complain of numbness or tingling. That is always something that is very subjective to the patient. If you ask them if their hand's numb, they're going to say, no, it's tingling, or they're going to describe a different sensation in that median nerve distribution. Most often, these symptoms are worse at night. The patients waken frequently with them. They say their hands are numb. They say they have to wake up. They shake their wrists to get thinking move, to get the feeling back in their hands. And they very often have a difficult time distinguishing what part of the hand is numb. Most of the time, they will complain that the whole hand is numb, even if it's isolated to 2 or 3 fingers. They will complain that the whole hand is numb. They may also complain of the numbness going from their fingers and radiating all the way up the forearm to the elbow to the shoulder. A number of patients come in to see me. They say, I have this pain in my wrist. It's kind of this numbness. It goes all the way to my shoulder. And that is very commonly, again, carpal tunnel. They also complain of some decreased strength and dexterity in the hand. This is probably one of the more common reasons why people come into the office. They will complain that their hand is numb all the time, but when they get to a stage where they cannot do up their buttons on their shirt, they start dropping things. That is when they start getting really concerned and show up in the office. Again, this is something that is very often bilateral, even though when you look at it, people say, oh, is it work-related? Is it not work-related? Why am I having it in my non-dominant hand? Very often it is bilateral, although again, one hand tends to be significantly more affected than the other hand. One of the late findings in carpal tunnel, when you look at this diagram over here, is thenar atrophy. So one of the concerns about the thenar atrophy is, yes, it is the carpal tunnel that can cause it, but a lot of times people can confuse this also because of arthritis in the base of the thumb. So you do have to be aware of the 2 options that is a possible cause of some atrophy in the thumb. But this, unfortunately, the atrophy in the thumb is a very late finding. When the patient comes to the office complaining of numbness in the hand or carpal tunnel type syndrome, one of the things you need to look for, some of the tests you need to look for are, the first one is a Phelan's maneuver, which is basically you have the patient flex their wrist down and hold it down. Now, one of the things that I learned during my training is people tend to do this Phelan's test and patients are sitting at a table or a chair. They have their elbows flexed and then the physician flexes their wrists. That can be a little confusing sometimes because people may have cubital tunnel syndrome. That is compression of the ulnar nerve at the elbow. And those symptoms may be a little confusing. So when you do this test, make sure that you have the patient's elbow fully extended. That'll take pressure off the ulnar nerve and concentrate only on the median nerve. The Tinel's is very straightforward. It's just you have to tap on the wrist right over the median nerve. Again, you don't want to ask the patients if they're having numbness or tingling. It's almost better just to ask them if things feel different in their fingers, if they feel any kind of change, because if you use different terminology from what they're used to, they will not answer you the way you're expecting. Diagnostically, again, what we're looking for to diagnosis is based on a huge amount on their history, the physical exam, and a definitive diagnostic test is an EMG, nerve conduction velocities. And those are very good. They're very predictable and really helps you understand exactly how badly the nerve is being compressed. So including a differential diagnosis, when people present, again, complaining of that wrist pain, that some numbness in the hand, you have to look at if they have a little bit of tendinitis in the wrist, if they have some tenosynovitis, if they have an infection in the joint or in their tendon sheaths that are causing problems. Diabetics, unfortunately, are very prone to developing carpal tunnel, and sometimes it's very difficult to differentiate between a diabetic neuropathy and actual carpal tunnel syndrome. Kind-box disease is something that will affect the wrist. It's avascular necrosis of the lunate bone, and what it can do is cause swelling around the wrist and cause the patient to have symptoms of carpal tunnel, even though that may not be the definitive problem. And finally, compression of the median nerve at the elbow, or pronator syndrome. Symptoms tend to be a little bit different. People tend to complain more of pain going down the forearm as opposed to numbness or tingling. As far as treating carpal tunnel, obviously some of the things you want to do is prevent activities that cause carpal tunnel. We look at conservative treatment, going down to surgery. General measures, again, although it's not hard to definitively prove that repetitive motions cause carpal tunnel, they certainly may exacerbate symptoms. And changing someone's behavior, changing their work habits at work may help with that. The use of vibratory tools can definitely irritate carpal tunnel, puts a lot of pressure on the nerve. And a lot of times, one of the first things we look at is changing people's workstations, how they work at their desk, what type of computer modem they're working on, trying to change their behavior so that they're putting a little less pressure on the nerve. A lot of people have come up with a number of ideas. The pen on the right, I'm not so sure that's going to make a difference, but certainly ergonomic keyboards and mouses do help put a little pressure on less pressure on the nerve. When someone is diagnosed with carpal tunnel, and again, this is usually when they first present, complaining of numbness overnight, they wake up with numb hands. One of the first things we look at doing is splinting. This, by the way, is not a splint we would typically use. Nobody would sleep with it, and they would shoot us if we try to give it to them. What we tend to use is the basic simple splint on the left, something just to prevent the wrist going into full flexion, full extension. Keeping the wrist in about 15 degrees of extension puts the least pressure on the nerve. So that is what we try to have people sleep in. Obviously, the small splints you see on the right are just something to help them protect their wrists during work, particularly at a keyboard. A lot has been made of oral medications. Again, when I talked earlier about pressure changes, people have tried diuretics, nonsteroidals, vitamin B6, oral steroids. The oral steroids will work for a short term. They will help relieve the patient's symptoms, but it's not something you're going to put a patient on long term. As for the rest of them, unfortunately, they do not work. They do not help that much. So once we have somebody diagnosed with carpal tunnel, again, we'll try the splinting at night. initially. If they have mild to moderate symptoms based on the EMG, the first thing we'll usually do is just try a steroid injection. We'll do some lidocaine, some prednisone in there, and basically the injection goes in just proximal to the wrist crease on the ulnar side of palmaris longus. And when you do the injection, you can actually feel as you go through, you can feel a little pressure change as you go through the transverse carpal ligament. As soon as you get through that, things become much lighter. It's very easy to inject. If you're ever doing one of these injections and you have a hard time injecting, stop right away. That means you're in the wrong spot. You're either trying to inject into a tendon or unfortunately even the nerve, which could cause some serious damage. Again, after an injection, we do recommend splinting to keep the wrist at rest, keep everything calm. If the first injection does work for an extended period of time, maybe up to even a month, a repeat injection is definitely a worthwhile option. If the patient gets an injection, says, hey, it felt good for 2 or 3 days, and the symptoms came right back, you're kind of probably wasting your time and the patient's time actually doing another injection, and you need to look at the next step. If you need 2 or 3 more injections, you're probably looking at a stage where, hey, we probably need to do something else. So we get to the next stage, which is surgery. Obviously, we're looking at surgery now. If patients have had conservative treatment, they've had their symptoms for an extended period of time, usually the obviously based on insurances, the EMG needs to be positive, and they've failed conservative treatment. They're showing motor weakness. When they're getting the clumsiness, they're starting to get some atrophy. That's when we need to look at doing surgery. Now, one of the things that I always explain to my patients when I do the surgery is our primary goal of the surgery is to stop things getting worse. 99% of the time, people get a huge improvement in the symptoms, but carpal tunnel is something that's progressive and does keep getting worse. So the first goal is to stop everything getting worse. The goal of surgery is to relieve pressure on the nerve. So this first diagram you're looking at here is if anybody had parents or grandparents that had carpal tunnel surgery done, basically you would have your whole wrist filleted open to release the one little bit of transverse carpal ligament. After this, you'd be in a splint for an extended period of time. Nowadays, again, the goal of the surgery is to relieve the pressure on the nerve. The way we relieve that pressure is to release the transverse carpal ligament. So no matter how you do it, that is the goal of the surgery. Nowadays, instead of the filleting the arm open, people either do it with an open technique that you see on the left with a much smaller incision, or on the right, they do it endoscopically, which is the way I do it, to again, just release the ligament, take pressure off the nerve, allow some immediate pressure relief off the nerve, and look for recovery. Going back, again, if you looked at that first technique with the arm filleted open, patients would end up with a splint similar to what you see on the left. Most of us nowadays end up with the patient with a little ACE wrap around their wrist that's on there for about 5 days. They take it off. They start using the hand again. Obviously, surgery is not without complications. There are risks to it. Probably the most common one is an injury to the palmocutaneous nerve that is a little inconsistent where it appears. Injuries to the motor branch of the median nerve are very common. Hypertrophic scar formation, again, can occur more often with open than closed surgeries. And anytime somebody gets surgery, obviously you worry about an infection, hematoma, or stiffness after surgery. But again, just closing up, so carpal tunnel is the most common peripheral neuropathy. Again, the pain and paresthesias are usually thumb, index, middle finger, and very rarely people will complain of numbness on the radial side of the index finger. Findings, Tunnel's and Phelan's maneuvers are very good, helpful signs, but quite honestly, the most reliable thing is the patient's history and an EMG. Again, so conservative treatment includes splinting and injections. Oral steroids help, but only for a short period of time. And if the patients fail those, it's time to aggressively look at an EMG or possible surgical intervention. So does anyone have any questions at all?
Yes, they have questions. So the first question is, now that more patients are working from home online, do you recommend a standing computer?
The standing computer is going to affect your back more than it actually is your carpal tunnel. I have a number of friends that I know use standing computers. They feel like they are much more comfortable. So yes, if you're able to stand, I would recommend one of those.
Do you recommend sending a patient to a specialist for the injection?
That depends on the primary care provider's comfort level with doing the injections. Some people are very comfortable in doing injections, some are not, and that is a totally individual thing as to how you feel about it.
And what is your recommended length of time for conservative care before deciding on surgery?
I usually give people about a month when they come into me and see me initially. If they've had no conservative treatment, I will start them off in braces, give them a month, have them come back, see how they're feeling. If they're not feeling any better, then it is time to be a little more aggressive.
Do we have any additional questions for Dr. Millard? Okay, thank you, Dr. Millard.
Thank you, Heather.
Dr. Daniel Pap will be presenting on spinal injections next. Dr. Pap is a board certified anesthesiologist specializing in interventional pain management. He has special interest in neuromodulation, spinal cord stimulation, and complex regional pain syndrome. Dr. Pap provides a wide variety of services, including spinal injections, neuromodulation, spinal cord stimulation, selective nerve blocks, radiofrequency ablation, facet joint injections, trigger point injections, and peripheral nerve blocks. Dr. Pap.
Hello, everybody. Thanks for joining us this evening. Let me get my screen up here and we'll get going. All right. Make sure this is working okay. Looks like we are good to go. All right, like I said, I'm Daniel Pap. I'm an anesthesiologist and interventional pain physician. I joined OrthoNeuro sort of at the beginning of the year. Definitely an interesting time, sort of right before the pandemic hit, to join a new practice. But it's a fantastic group. One of the main reasons, like the appeal, I love that we can sort of offer sort of a one-stop shop for patients kind of across the board. Everything from physical therapy up through surgical intervention and everything in between, including spinal injections, which we'll talk about more today. It's just a nice collaborative effort that we can sort of offer the full spectrum to patients. And it's nice to work in close proximity, because I'm often, even mid-clinic, kind of walking 10 feet down and asking some of the spine surgeon questions. And it's just a nice collaborative effort, and the patients benefit from it. So, okay, so today we're going to be talking about some common spinal injections. A little background statistics here. Let's make this full screen. There we go. So as some of you know, because you see this in your practices daily, sort of the prevalence of back pain and neck pain. So 80% of adults experience low back pain at some point in their lifetime. Back pain and neck pain consistently, year in, year out, rank in the top 5 of disabling disorders. Most common cause of job-related disability, leading contributor to missed work days. Number of Americans experience low back pain is on the rise. And this was even prior to the pandemic. I've seen quite a bit of people's normal daily activities and routines have been really disrupted, whether it's people going to the gym or some of our older patients going to the Y, and sort of even just their normal routines where they're doing sort of, some of that low impact activity that they're not doing. And you can really, it's quite amazing how some seemingly minor changes in activity, you think you're comfortable at home, but really you sort of have some deconditioning of paraspinal muscles and postural tension and core strength. And I've seen even an uptick of people's symptoms starting with the pandemic and that disruption of activity. Greater than a third of adults at some point say the back pain impacts everyday activities. Again, this isn't just people trying to do sort of elective things. This is just people getting through their normal activities, getting dressed, doing their normal ADLs. And this is a big cost to society, as Americans spend at least $50 billion annually on treating back pain. So some therapeutic options, kind of starting with diagnostics. Imaging definitely has their role. From a non-surgical perspective, I sort of have, obviously it's a different view. When you're seeing a surgeon, imaging correlates with certain symptoms. Is there a possible surgical correction? That's sort of part and parcel. When you're seeing one of the spine surgeons, it's useful to have an MRI prior to seeing them. So there's certain things they can comment on. Does it correlate to your symptoms? Is there something that they can do from a surgical standpoint? For me, again, I'm often seeing people with pre-existing imaging. But for me, from a non-surgical standpoint, I'm guided by the symptoms in the patient's history. So yes, imaging can be useful, and I'll use it as a guide, and it can help sort of confirm sort of my clinical suspicions. But basically, history and symptoms are sort of the most important thing to me, because again, as we all know, if we're kind of rushing to get MRIs and sort of run-of-the-mill back pain that hasn't been present all that long, depending on the patient's age, you're going to see a lot of sort of degenerative, normal age-related changes, and it just confounds the picture because there's a lot of incidental findings that aren't related to their clinical picture whatsoever. And again, I'm sure you guys know with patients' portals, and they access the radiology read from online, they're asking about every little detail. Obviously, the radiologist can have a pretty normal or pretty routine looking, age-related, appropriate MRI, and there's lots of different comments on it. But what is actually contributing to their pain symptoms? Sometimes the limitations, X-rays, for example, just don't show a lot of soft tissue definition. They don't show any of, you're sort of seeing it by absence in terms of reduced disc height, if there's possible disc herniation, sort of some arthritic and facet changes, you can see those. But again, there's some limitations. X-rays definitely are important if there's a suspicion for the sort of the rule out thing. So elderly patient falls, you want to rule out a compression fracture because you have a certain window where you can intervene, and you can send them to, interventional radiologist, spine surgeon, pain physicians that can do a kyphoplasty, for example. But again, the imaging is not, in terms of my non-operative approach to patients, imaging serves as only a guide, and it really should be guided on an individual basis by the severity of their symptoms, their history, and their exam. So different things we can do. Obviously, there's multimodal medications. The most common 3 that, again, all of you probably use these routinely in your practice. And they definitely can have some benefit. So neuropathic or nerve pain medications, the most common that we use: gabapentin, Lyrica, nortriptyline, amitriptyline, Topamax, to name a few. Muscle relaxants for that muscle spasm, myofascial pain, most commonly tizanidine, Flexeril, Robaxin, Baclofen. NSAIDs and arthritic medications have their role. Mobic, diclofenac, higher dose ibuprofen, the common ones that we use. And then narcotics and opioids, I would strongly encourage, they have their role for acute pain. Obviously, it doesn't just have to be surgical pain. That's sort of their ideal use. For short-term use on an as-needed basis until things improve. There's non-operative acute pain issues where you can benefit from a short course. But it's one of those things, I know it's tough when you feel like you want to do something for the patient, and people occasionally are known to exaggerate their pain scores and their functional disability, and we want to do something for them quickly. But there's just no great long-term evidence data to support pain scores, functional ability, disability. It's just not there. And so one of the things at OrthoNeuro that we can do to sort of help combat that, so you're feeling like you can do something for them immediately, is we like to get people in as quick as possible and see some of these problems sort of in that acute phase where we can sort of intervene and sort of take away the need for that short-term bridge. Again, in some cases, as you all know, like they have the role, and for acute breakthrough, they can be appropriately used. But I just would encourage you to, as much as possible, and it's sometimes a difficult discussion with the patients, to just try to see if you can hold off on writing the 30-day and longer and multiple pain pills a day kind of right up front. I know it's easier said than done with certain patients and sort of the expectations that a lot of us are under these days. All right, and then so physical therapy, another option. That's physical therapy to me is always the right answer. It's never the wrong answer. In some of these acute pain situations where you have a lifting injury or an impact where you have acute disc herniation pressing up on a nerve with debilitating radiating symptoms, I mean, 6 weeks of physical therapy that the insurance mandates before you can get your MRI is kind of silly because they can't really get through it. They don't tolerate it. It's super frustrating. It increases pain. So it's always the right answer, but it's nice to, in some cases, I like to do a couple things to sort of get better managing control of the pain. And then they're going to get more out of it. There's going to be less frustration. There should be much more benefit when they can sort of do some of those things that can shore up, again, postural muscle strength, core strength, and things that can hold the spine in better alignment that can help with some of these symptoms long-term. And then finally, there's some interventional options and injections, which we'll talk about the rest of the presentation. We're kind of familiar with this. At some point, I feel like we're all sort of taught there's an escalating hierarchy of things starting with conservative therapies and escalated from there. But I'd say, yeah, in general, this has some place, but I'd really encourage some pain issues to really be taken on an individual basis in terms of severity of symptoms. Because again, sometimes, again, in the case of that acute disc herniation, like, physical therapy and over-the-counter medications just aren't really going to do anything. There's some new evidence and data in the pain literature to do some of these more advanced therapies we'll talk about a little later. Spinal cord stimulation, there's some new peripheral nerve stimulation. There's some good evidence that early adoption of these things can have really profound impact on patients' overall development as they start with an acute pain problem that goes on to progress to sort of a chronic year-long thing. So again, not letting necessarily years and years go by of failing everything before you get to some of these advanced therapies. There's some good evidence to support that. And even from the beginning, we don't necessarily have a diagnosis up front before we're sort of going through this process. A lot of our injections are both diagnostic and therapeutic for a variety of reasons. One, there's sort of multiple overlapping areas of pain that can be coming from multiple places. Again, we'll touch on these with some of the injections. But sometimes we're working through the diagnosis, even though I'm always trying, when you send patients over, we're trying to alleviate their pain and help with their symptoms, obviously. But really the goal, the focus goal should be on function. We're trying to return patients back to their normal daily activities, their ability to do their normal routines, get through their work week and do things they need to do, and ultimately doing things they like to do. So a lot of times, again, I'm sort of treating pain, but I'm always thinking as I'm going through, I'm working on trying to identify what is their main pain generator and what can I do about it short-term, medium-term, and long-term. Again, so I sort of touched on these. There's multiple roles of injections. Oftentimes, if someone does have a surgical problem, and again, mainly from a spine surgeon perspective, they will send me diagnostic, say a transforaminal epidural at a certain level that maybe can provide short-term pain relief to further support that maybe a definitive decompression at that level may be the best option for the patient. So there's some diagnostic roles. And again, the injections, I like to make them as therapeutic as possible. Even when we're doing some of these diagnostic blocks, you can often add a little bit of steroid. So it's working beyond just the couple hours. If you use lidocaine, maybe 8 to 12 hours using bupivacaine, we're going to actually provide some therapeutics. We're putting them through a procedure, bringing them in to do it. I like to give them more than just a few hours of relief. And to that end, some of them are more short-term relief, and then up through longer-term relief with neuromodulation can be something that can help for 5 years, 10 years, and beyond. And then again, these are best used not in a vacuum, but part of a multidisciplinary approach with good communication between the referring physician and the primary doctor, a nurse practitioner or PA that's really the quarterback of their care. So I'm just one part, and I want there to be, I don't want you to just, I do sort of an injection in a vacuum and that's that. I like to kind of see the whole picture, and again, really focusing on getting patients back to their normal activities and function is a big goal. And I'm always available if there's any questions when we do kind of go back to the primary care provider. If there's what can we do, or you guys know the patients best, and there's some insight that you can always share with us. We always want to be available to how we can best help serve the patients. So again, these are best done sort of in that multidisciplinary approach, whether, like I said, all the way from using sort of the non-operative physical therapists and up through surgery and everything in between. And also a multimodal approach in combination with some of those, multimodal non-narcotic medications, et cetera. So some of the most common injections that we do. So this is the most common one in the office. Doesn't require much in terms of authorization. There's no imaging. Trigger point injection. So some of you probably do these in the office. It's very safe, and honestly, this is a great thing. I'd be happy to even, if again, Dr. Millard kind of alluded to patients, providers, different comfort levels with injections. But this is one where someone has sort of a new strain or sprain in the low back, and I've really seen these, especially in some younger healthy patients that are active, maybe even sports injuries, where you can do these and you can sort of break that cycle, break that spasm pain, and help return patients. It sort of clears up the problem. I've just had great results. The most common ones we do: lumbar paraspinal trigger points, paracervical muscles, upper trapezius, in between the shoulder blades. There's multiple layers of muscles. These are some common things that we do. And often we'll do these sort of in advance. You're treating sort of the one aspect of pain. They may have some arthritic mediated lumbar facet pain, for example. We'll talk about that on the next slide. But there's an element of myofascial pain. So that goes back into that overlapping thing. There's multiple pain generators. There's always not always, but there's usually part of a myofascial component to their pain symptomology. Unfortunately, there's no test, image, EMG, MRI, anything that's really going to definitively tell the patients their subjective pain experience. Okay, 20% is coming from the muscles, 50% is coming from the facets, another 30% is coming from discogenic focal back. It just doesn't exist. So again, that goes back to some of these injections. There's a diagnostic quality to, we don't know necessarily how much it's going to help you. We think it's going to help you. These often can do quite a great job for muscle pain. They're done often, sometimes in physical therapist's office and chiropractic with even dry needling with no medications. The way we do them in the office is we mix kind of our standard local anesthetic, usually a long-acting bupivacaine, with a particulate steroid, which just sort of stay there at the site a little bit longer. All right, so I don't know why that went back. Hold on one second. All right, so this is the most common injection that we do under X-ray guidance. Epidural steroid injections are used for a variety of things. It's pretty much always involves some sort of nerve root irritation. So that's what we're trying to treat. So the most common causes, you have disc herniations, you can have lumbar facet hypertrophy, and we'll talk more about that on the next slide. There's wear and tear, degeneration of the spine that can narrow the exiting foramen where the nerves exit, but all of that results in symptoms down the leg. That's sort of the key. We're typically not doing epidural injections for axial focal back pain. There is some use for lumbar spinal stenosis as an exception, where that narrowing can cause some axial back pain, and then annular tears, discogenic pain, but these are much less common. The most common cause, disc herniation, narrows the space where the nerve exits, you have some nerve root irritation. We're putting the most potent anti-inflammatory right to the source. So some things people do in the meantime while they're waiting to see us, you do a Medrol dose pack, for example. So if you think about that, the medication doesn't discriminate. So a little bit of that steroid as you take an oral medication is going to go literally everywhere in the body. And that can still help sometimes, at least for a short period of time, for these symptoms. So we're flipping it and putting all the potent medication right to the source. And then only a tiny bit is going systemic. So you're getting the maximal benefit from the anti-inflammatory and the steroid, and you're minimizing those long-term effects of the steroid. So again, as Dr. Millard said, prednisone and different steroids can be obviously kind of life-changing for a lot of these symptoms, but unfortunately, due to the profound long-term side effects, we can't have people on high-dose steroids for long periods of time at all. And again, the key to these epidural injections typically is a radiating component into the legs. much less likely to improve focal back, as I talked about. And the other thing is some of these patients, especially when this is their first, even second time they have a sciatica type symptomology. So I don't know the exact spine surgery literature, but I think I was talking to one of the surgeons, it's as high as 8 out of 10 patients are going to have just one episode, maybe two, and then it resolves and doesn't come back. So the natural history, discs do recede. These problems can get better. And what the injection serves to do is sort of jumpstart that healing process, and it shortens that natural recovery time. So a lot of times, you know, the golden question, well, how long is this going to last? I mean, you can't answer that. That's part of the trial of the injection. But I would never say, like, sometimes we'll do this injection, patient's symptoms resolve and they never come back. Now, does the injection last for 5 years or 10 years or forever? Absolutely not. But it helps them get through this episode. This is a good one to use, as these can be episodic in nature. If someone has another episode, they recognize it. We can get them in quick to sort of stop that episode and stop it from progressing to lost days at work and lost function, et cetera. So again, that's one of the most common ones that we do. This is probably the second most common. So focal low back pain, probably the biggest contributor to axial back pain. This is your spinal arthritis pain. Not a lot of great pictures can kind of show this, but I thought this one did a decent job. So the shock absorbing disc is in the anterior part of the spinal column, and it makes a ring where the spinal canal and cord and dura and fluid is in the center. So posteriorly, each vertebral level articulates it. Bilateral facet joints. These are facet joints from the levels above and below. So that's why it's listed as a segment. And so this is actually just like shoulders, knees, hips, you can get arthritic changes in these joints with time, normal degenerative changes. And this is one of the most common areas that we treat. So when we say like spinal arthritis or low back arthritis, this is typically what we're referring to. The X-ray findings have lots of different sort of synonyms that they like to use, fancy terms. Lumbar spondylosis, facet disease, facet arthropathy, facet changes, all that is talking about these joints. Now, in terms of the diagnostics and therapeutics, you can do actual intra-articular joint injections. It's just such a small joint. It's a very low volume. You can't get a lot of medication in there. I mean, I do those occasionally. That's more reserved, maybe a younger athlete with a focal, like unilateral facet, and that's the lone finding on imaging. But in general, I usually am blocking these nerves. So the nerves on here are the actual medial branch blocks. Those joints are supplied above and below. So we can actually, under X-ray, we use just the anatomic guidance. So we do a nerve block. It's diagnostic. About half the physicians just use local only. So it'll last for the duration of the local. You repeat a second test. That's sort of an insurance requirement across the board to get the next step, which is a radio frequency ablation where we use targeted heat. But I like to add a little bit of steroid to it because I've seen people have a great response, even several weeks, even several months, where the blocks alone are giving them that functional benefit. So I'm not just putting them through this procedure for 6 hours of relief just to do it a second time to kind of get to that RFA eventually. Along the way, I'm really trying to give people that functional benefit where they can, again, make progress in their activities and do things they need to do. Again, diagnostic and therapeutic. Talked about the branch blocks versus the facets. So these are used interchangeably. You'll hear that, or you'll hear people talk about facets. That's what we're talking about. So the actual joints most commonly are done with the injections by the actual block that's amenable to that next procedure, as opposed to that intra-articular facet that would go right in that small little space there. All right. And then this is the next step procedure. The RFA is essentially the same outpatient procedure. We don't have to use any anesthesia. It probably takes only an extra 2 to 3 minutes longer than the previous blocks. Patients tolerate these great. So we numb up the spot, we put the needles down based on anatomy, and then just take a couple minutes to do neuro, sensory, and motor testing to sort of really hone in. It's very precise where we're going to do that little thermal insult to sort of kill off those targeted nerves that cause that pain. Those from the last slide, those medial branches, they die off with that thermal insult. They eventually do regenerate. And so that's why this isn't like a definitive fix. This can last typically for about a year with the newer devices, do a good sized lesion, and they can have sort of a V tip. So you're getting a bigger lesion and doing more of the medial branches. So we're getting on the short side, maybe 8 months, but usually 10 months, 12 months, you can usually get out of this. And so it's like an 8-minute procedure. The patient can come once a year to do you don't have to repeat the blocks to do it. And again, I have lots of patients, they get great functional benefit out of this. And that year really gives them a nice window where they can make progress on their activities, walk more, do more things, increase that core strength, increase that postural muscle strength. And when the nerves do regenerate, they don't necessarily have the same effect. You can have some attenuated symptoms, have a little more, strength there to hold the spine in better alignment. So it just gives people a nice window. Again, it's not a definitive fix as nerves regenerate, but it's just a nice longer than lasting, a week or two with some of the steroid injections. Real quickly I'm kind of running on time here. Just a couple more of the common ones. SI joint is, I feel like, a very sort of underappreciated, underdiagnosed one. We're always kind of focusing on the lumbar spine, but this is a common pain generator. The sacrum is essentially where the upper body meets the lower body. The sacrum meets the pelvis. It's under a lot of stress and strain. I put this little picture up. I show patients this a lot. It's uncommon, kind of ignore this anterior part. I don't see that. I've seen that occasionally. And then the part below the knee is very uncommon. But this other part here, as you can see, this sort of perfectly mimics lumbar radiculopathy. So sometimes, again, going through that process, and even piriformis syndrome, there's just a lot of possible things that clinically can be indistinguishable. And we're doing common things being common. I'd probably start with some sort of right-sided targeted epidural. But say that helps some, but not enough. They still have that focal pain below the belt line into the buttock, maybe going halfway down to the thigh, but not past the knee. Then I'm always kind of SI joint as a close suspicion next. The nice thing about this, there is, again, an RFA option where essentially similar to the medial branches, there's sacral lateral branches that we can do a radio frequency ablation. And there's even a surgical option that's very specific for a candidate that has like predominant pain generator from their SI joints. We can do there's different criteria, but essentially a series of diagnostic SI joints, a specific protocol, and it can be a candidate for an SI joint fusion, which can be life-changing for the properly selected patients. SI joints don't have to move all that much. We're talking like 1 to 2 degrees, 1 to 3 degrees is all their range of motion is. And sort of fusing that motion can have profound effects on some of these pain symptoms from the SI joint. So this is a little less talked about, but a real common thing that I see all the time that we can intervene on. And then finally, we'll just briefly talk on spinal cord stimulation. Essentially, the most common uses are after, again, I'm talking in general, all of this, I talked about the lumbar spine, but we have these same things that happen in the cervical spine where there's facet injections and epidurals, obviously. I sort of tailored this to the lumbar spine. But again, for back pain and leg pain after surgery, essentially what you do is you thread 2 epidural leads, probably the similar size as like a labor epidural. These tiny little leads, I have a picture of the fluoro here where you can see in the posterior epidural space, and they go into the mid-thoracic area. And essentially kind of like a Bose noise cancellation system. This is a sort of pain modifying system where, again, we're not using this for new pain where the body is sending you a signal that there's something wrong that needs to be investigated. This is obviously for chronic refractory pain that we can block that signal. So the traditional stim sort of replaced the radiating pain with what it called pleasant paresthesia. But some of the newer programming and newer higher frequency devices can do non-paresthesia. So essentially the patient, we put in these leads, we have a 7-day trial. They have essentially like I think there's apps for the iPhone now, and you can modify, turn the program on and off, try different programs, and essentially you're modifying your pain signal that is going back up through the spinal cord that you're receiving, and you can cancel out some of that chronic pain. So this is, again, a great thing for past surgeries and revision surgery. There's no option. CRPS in the upper extremities and lower extremities is a common use. There's some newer focused peripheral nerve stimulators that can do just specific nerve-related body parts, foot, hip pain, knee pain, very specific as if you don't have to do the whole back and leg. But this is the technology is improving all the time. And this is one I alluded to, that there's some evidence to use this earlier, sooner than later in certain cases where there's not other great options or the patient's not a surgical candidate. This is just something that there's a ton of research, and it just, the technology is improving, and there's a lot of good success out there for patients. And just a couple recap things. Definitely strong evidence to support the use of interventional therapies for back pain. And again, I'm doing injections with purpose. I'm not doing them just to do them. We want to do these in the setting of overall patient care that helps benefit the patient's functional ability typically. And again, in some cases, we're helping with pain and symptoms that can be acute and severe, and we can help kind of calm those things down right away. These are all outpatient. I use no IV sedation. This is all done under local. Patients tolerate these great. Most of them are 5 minutes or less. They're in and out. They can, there's no NPO. They can have coffee and breakfast and they can do their activities as tolerated. I have patients that do these and go to work the same day. The interventional therapies are most successful in the setting of, as I mentioned, I touched on before, that multidisciplinary approach. Novel therapies, again, some of the neuromodulation definitely offer some hope for some historically very difficult pain symptoms to treat in the past. And then again, I've said this multiple times, and I don't think I can overemphasize it enough in terms of patient expectations and things that I definitely tell them on their new patient visit. It's not necessarily, unfortunately, there's not one thing that's wrong that we can pinpoint and fix, but we can help it make it more manageable, improve your function, activity level, get you back on your feet, get you back up and moving, and get you through your day and get you back to enjoying things you like to do. So, all right. So I think that concludes my talk here. Let me exit my screen here. And then we'll get to some questions. Heather, let me.
Yes. The first question is, on average, how quickly are...
Hold on, let me unshare the screen here real quick.
Okay.
Okay, go ahead. Sorry, go ahead.
On average, how quickly are you able to see back patients for back pain?
So that's sort of a moving target, but again, the goal is quick. We want to get people in a week or two. We don't want several weeks wait. We have a lot of volume. There's 7 spine surgeons in OrthoNeuro, so someone can get you in for evaluation quickly. We are expanding, and there's just a lot of patient need, as I've sort of alluded to, and I'm bringing on a pain physician colleague here. We have someone that's likely joining us in 2021, but our goal definitely is to get people in quick. And as you guys all know, the difference patients have severity of symptoms. When there is something that you are concerned about and you really want to get someone in really quick, again, I would encourage you, Heather can give contact information or even my cell phone. Like, I'm here to help. So there's certain symptomology, certain pain, what's the word I'm looking for? Basically conditions that we want to get you in super quick. And I can sometimes, even if there's a wait for a routine visit, I can expedite visits and get people in quicker than the next availability per se. So I would definitely encourage the providers to reach out to us, because that's something that we're definitely trying to offer.
The next question is, how do you advise patients who are going to a chiropractor concomitantly?
Yeah, so I mean, the chiropractic, again, we don't have, as physicians and NPs and PAs, and you guys know, we don't necessarily know there just seems to be a wide variety of what chiropractic care offers at some of these places. So I have patients that swear by some of their chiropractors. I feel like there's sort of a wide variance of practice patterns, but I don't think it's going to hurt. I mean, these are rare, and I can let my neurologist colleagues talk more specific. There's certain conditions in the neck where it may be a little risky to do manipulations in terms of vertebral disease, carotid disease. I mean, it's more than theoretical. There's actually been some injuries of that sort. But again, in general, I think chiropractic care can be a nice adjuvant to the stuff that we're doing. Lots of my patients see chiropractic care, and I would definitely not discourage it. I think there's a lot of benefit to be had. It just really just sort of depends, but I don't think in general, it can't hurt, and it's an extra thing that can kind of help patients get through some of their symptoms.
With chronic back pain, often patients request FMLA paperwork. Any recommendations for places to send patients for functional capacity testing?
That is a great question. It's not something that I have done a ton from my current position. I've been here since end of February, March. I'll have to get back to you on that one. I don't necessarily know one offhand. I'm sure all the big systems in town offer it. I'll have to come back to that one, but I can definitely get an answer for you. That's not something that I routinely am sending out, but I think that definitely I talk about it with patients. That's a really important part in really establishing true disability in terms of taking off time work, and who, pain is such a subjective thing, really hard to quantify, and some sort of more objective testing in terms of a full functional exam like that just has a really critical role, I think, in sort of teasing out a fair way, an equitable way to do that for patients across the board. So sorry, I don't have an answer, but I will find out the place in the town to do that. I'll get back to you with that one.
Do you treat CARPS? Complex regional pain syndrome.
We do. Yeah. Yeah. So there's lots of different things to do for that. It's again, one of sort of those dreaded diagnosis of exclusion. It's a clinical diagnosis. There's not a lot of rhyme or reason sometimes why some sort of, whether known or unknown, insult to the nervous system manifests in these abnormal changes. It's one of those things, but there's lots of different things we can do for it, from neuropathic medications for some compounded topicals for hypersensitivity. There's sympathetic blocks of the upper extremity and lower extremity called stellate ganglion blocks in the neck that can help with upper extremity, lumbar sympathetic blocks. And those patients do respond really well to neuromodulation therapy as well. So that's definitely something I'm happy to see anytime. It's one of a common thing that I see.
Do we have any additional questions for Dr. Pap? Thank you, Dr. Pap.
Thank you so much for your time, everybody, and stay safe out there.
Our final speaker of the evening is Dr. Martin Taylor. Dr. Taylor is a board-certified neurologist specializing in the diagnosis and treatment of Parkinson's disease, head and neck and neuropathic pain, movement disorders, EMG, EEG, and botulinum toxin therapy. Dr. Taylor will be speaking on Parkinson's disease today. Dr. Taylor?
Thanks, Heather. Let me go ahead and share my screen and get started. All right, just make sure I'm okay to go. Heather, you can see my screen?
You're good to go.
Okay. All right, so I'm going to be giving you an overview of Parkinson's disease. What I want to do is go over, what the major symptoms are to Parkinson's disease, really kind of tease out a couple of nuances, talk about how to distinguish it from other tremors and other mood disorders, and then talk about the basic treatment that we use, the paradigm we use in treatment, and also some new treatments that are exciting down the line here. Who gets PD? So PD is one of the most common things that we see in the neurology clinic, approximately 1 million people across the US, and typically onset is between 60 and 65 or 70. Just realize that patients can develop it and be diagnosed as early as the 20s or 30s, very uncommonly before the age of 30, even before 40, and not uncommonly in their 80s or so. The big thing is that when patients have disease that's early, and early is typically even between 50 and 60, we always scratch our head and make sure that there could be something else going on, and there are different features that can occur, and we can be sure that it is Parkinson's disease, but obviously we don't want to make the wrong diagnosis too early. There are other patients that also have Parkinson's disease that look like idiopathic Parkinson's disease, that's classic Parkinson's, and then later on they change over time when they realize that there's something else, and we can talk about those diseases too. So only 8% of the population has the onset before the age of 40. And, everybody knows Michael J. Fox, and they don't really get, for the most part, that when they see him moving like this is the dyskinesia from his medicine and not the Parkinson's disease. But, so it really gives Parkinson's I would say a bad name, but a misunderstanding about what the diagnosis is, what the symptoms are. So what are risk factors? So obviously increasing age, particularly that age group. Now, family history, yes and no. The reason we say that is there are some cohorts that you can predict because the gene is so strong that patients are going to get Parkinson's, but for the most part, it's sporadic and you can't tell, but it does increase your chance of Parkinson's disease a small amount if they have it in the family history. So males and Caucasians more likely, and there may be some environmental factors. We're not sure, potentially heavy metals, pesticides, and proximity to industries. And we think that things like caffeine and smoking may actually be protective. So we talk about idiopathic Parkinson's disease, which is 75% of the cases, atypical Parkinson's disease, which are Parkinson's pluses. And I really don't want to focus on that today, but if you have any questions about that, feel free to ask. And then there's secondary Parkinsonisms. I want to talk about the secondary Parkinsonisms just briefly, and because they can mimic Parkinson's disease. And we really do say idiopathic Parkinson's, which is classic Parkinson's, as the main focus of what we're talking about today. So medications, as you know, can cause Parkinsonism. Typically it's over time. Usually it's antipsychotics, but even long-term use of things like Phenergan And in the literature, even things like antidepressants, that even SSRIs, I've really not seen that in my practice, to be honest with you. Certain toxins can cause Parkinson's-like symptoms, stroke or trauma, but that's pretty uncommon. So patients don't usually present with tremor, but they can be stiff or slow, obviously, if they've had a stroke. Hydrocephalus, and we're talking about NPH. So patients can be slow, they can be stiff, they can have problems with ambulation, and they can look like they have Parkinson's disease, but of course they don't tend to respond to medications, and they've got other issues. Remember, when patients have NPH, we talk about the 3 W's: wet, wobbly, and wacky. So wacky would be dementia theoretically, but wobbly is really not problems with ataxia, but apraxia, so they have difficulty moving their feet. And that can look a little Parkinsonian too. And then there's some metabolic abnormalities. We talk about abnormal copper metabolism and iron metabolism, which are pretty unlikely to cause a problem. So what are the main features? So of course, tremor, rigidity, bradykinesia, and postural instability. And those are the motor symptoms, and then there's non-motor symptoms. So what are the most common things that people have? And actually, the amazing thing is that there are 2 things that can occur early, or 2 or 3 things. This is not just a brain disease, this is a brain gut disease. And the patient's gut symptoms occur typically much earlier. So constipation can occur very early in the case. Sleep disorders can occur, and that's actually a big feature. And people will have early in the disease, before they even have Parkinson's symptoms, they can have REM sleep disordered behavior. So what is that? So as you guys know, that's basically thrashing and lashing out and having vivid dreams where you're actually hitting your partner or acting out an act. So people will call them night terrors sometimes, and that the patients may not remember them. But the big thing is that their body is not essentially asleep when they're going through REM sleep. And also anosmia. So anosmia can occur early. So I always ask about those things, especially to the spouse, if they have those 3 things at the onset, if they have a patient with tremor that presents specifically, to see if they have any of those features. Okay, so tremor specifically, 50% of the patients have tremors as initial symptom. It may or may not be bothersome to them. Remember, it's resting, it's pill rolling. And I guess back in the day, they used to roll pills this way. Now I guess people roll other stuff this way. So that's the feature. But a lot of times you have to distract the patient to see it. So it's obviously unilateral, and it can be on either hand. And typically it's worse on one hand, but can be present bilaterally. That arm is the same arm that's actually rigid, typically, or slower. And patients can have dysfunction higher up, even in the shoulder, because they don't move their arm. I have a lot of patients that, earlier in the disease, they have a problem with their shoulder, and they get an EMG or something, and I realize, well, you know what? You don't move your shoulder. You have a problem with your shoulder because you've got Parkinson's disease. So they can have a sustension tremor to somewhat, but it's not usually as prominent. But if somebody comes in and says, listen, I have a tremor that bothers me, it's worse in one hand, it's my dominant hand, and it happens when I'm holding an object or doing something, that's typically not Parkinson's disease, but patients can have some of those symptoms with it. They can have a jaw tremor and a leg tremor. Patients do not have a head tremor with Parkinson's. So if you see a patient having a no tremor of the head or yes head tremor, that's either a central tremor or cervical dystonia. Now, patients with Parkinson's are more likely to have cervical dystonia. That's a twisting or turning of the head with tremor, commonly with tremor. But patients that have a central tremor, I always tell my patients, do not turn into Parkinson's. So that's an important point. It can spread to both sides. People can be very rigid on both sides. And I mentioned distraction techniques. So if a patient is relaxing in their chair and they have their arms like this, I'm trying to show you my arms here. Basically, I'll have them relax one hand, and I have them draw a circle, draw a square, draw different kind of figures. And I'm not watching this hand so much. I'm watching the other hand to see if a tremor comes out. And that tremor on distraction could be noted also when they're ambulating, and that's not present necessarily at rest, or because they have increased tone, so they're not really resting the whole time. So rigidity, as we talk about, this is lead pipe. So it's not like spasticity where there's a catch. It feels the same throughout the plane, and you want to check one arm compared to the other. The arm that has the problems with the slowness and the problems with the tremor is most likely the one that causes or shows the rigidity. And we call it lead pipe because it's throughout the whole plane. And what do you feel when you're feeling cogwheeling? So cogwheeling is actually the tremor superimposed on the actual rigidity. And we typically may see that if the tremor is more prominent on one side. Let's talk about bradykinesia, but let's also talk about abnormal movements. So typically patients will have slowness, but they'll have uncoordination in movement. So we check for speed, and you can in a gestalt, you can look at the patient and see they're moving slowly, but we also see other things. So they have a decreased facial expression. The biggest thing really is blinking. So I watch people as they move their eyes, and when they come in, you can see if they have that or not. And then they move slowly in general. We check this with finger taps. So we check one finger tap, and we look at also the other fingers. The most important thing is to look at symmetry between one hand and the opposite hand finger taps. We want to see large volume, quick taps. And so what happens in Parkinson's, they get smaller and they get slower, and they also become uncoordinated. So they can't really form. So the coordination becomes decreased. And you should see a significant change if there's a lot of tremor in coordination on one side compared to one side versus the other. So akinesia, so bradykinesia, slowness, but akinesia is absence of movement. As the disease progresses, you can have patients that literally get frozen and can't move. And that's not typically that often that we see that, but we see more often they take a step, a gait, walking, and they stop, they freeze, they move. And when they turn, they may turn and take several steps. We call that turning on block. And that's a typical Parkinson's symptom. So when you talking about gait, and we'll get to that postural stability next, ambulating the patient is so important. And this talks about gait and stability next in the next slide, but it's so important that we basically walk our patients without a device if they can, 25 feet, and we always time them. And it's a really huge objective measure about how they're doing, because they come in, it may takes you six seconds to walk 25 feet. It may take them 10, 15, sometimes even 25 seconds. You put them on med, it even enforces the diagnosis. Even if they come back and they say, well, my tremor's not better, but it took them 20 seconds to walk 25 feet. Now it takes them 12 seconds. And after you put them on medicine, and that's obviously diagnostic. So postural stability can occur typically in advanced, farther stages of the disease. They have poor postural reflexes. We pull them back, and they can't right themselves, and they tend to stoop forward. They may lean over one side, and they're just unstable. Now realize that there could be other reasons. They could have myelopathy, they could have neuropathy and other issues, but postural instability is a problem by itself. Now, there are a lot of other intangible or small things that occur. Sialuria can occur. We talked about constipation, and even problems with urination can occur at times. There's a lot of other non-motor symptoms that can occur in Parkinson's disease, especially regarding the gut. Remember, the patients later in the disease can have dementia symptoms. And then just like in patients with dementia can have Parkinsonism later. And remember that if you see both those together in a relatively short time period of 1 to 2 to 3 years, you want to think of Lewy body disease, which can present looking like Parkinson's disease and dementia at the same time. So what are other autonomic symptoms? So low blood pressure, big problem for patients. Basically, they stand up and they can't, their pressure drops. And they may have actually hypertension laying, problem swallowing, I mentioned constipation, drooling. Depression is very common, obviously in these patients, dementia, hallucinations later, and delusions. And that's been a big issue recently. We do have some new medications for that. I mentioned sleep dystonias and also dystonias. So cervical dystonia being the most common, but commonly we'll see a patient when they walk, they'll have toe clawing, and then they're most likely to have a dystonic posturing or movement of a foot or a limb, typically it's a foot, on the same side they tend to be dystonic with a tremor. So how is it diagnosed? As you know, it's clinical presentation. So there's nothing that you could do to necessarily say this is Parkinson's disease, with the exception of your clinical examination, the history, and potentially response to medication. And of course, if you put them on a cinematic or a dopamine agonist and they get better, it also clinches the diagnosis. So always consider other reasons for tremor. Remember, essential tremor can occur as early as the age of 15 or even 10, and as late as the age of 80, 85. Usually there's a familial history, but it can start at any age. And just because the patient's 80 doesn't mean it couldn't be essential tremor, but it's usually bilateral with essential tremor. You can see it when they're writing. When we do Archimedes spiral, you can see the tremor. You can see it when they're writing also. Remember, Parkinson's disease, that Archimedes spiral that we use gets typically smaller. I always do a CT of the head. Don't always do an MRI scan unless there's atypical features. I really just want to make sure there's no mass or tumor, and also rule out NPH. I like to look at the scans myself. I don't rely on the radiologist. I want to see, a lot of times there may be atrophy, and they may say that, oh, the ventricles may be big a little bit. They may not say anything. And I've seen patients that come in and, you know, they look Parkinsonian and there's something not right about them. And I do a CAT scan and it ends up being NPH. So something that you want to rule out that you can treat differently and make sure you're not missing that. So an MRI scan, if there's atypical features, obviously if somebody has a big stroke risk, but that's a pretty unusual presentation. There are really no labs with the exception of maybe a thyroid to get with these patients. And then why get a DAT scan or some sort of nuclear study? So there's two camps on what the DAT scan can show. So we're looking for decreased dopamine metabolism in the substantia nigra in the areas where dopamine is made, okay? And so what you can distinguish is a patient who has a dopamine dysfunction, and that is Parkinson's plus all the things that are like Parkinson's, all the Parkinson plus syndromes, versus a central tremor if a patient has tremor. It's all you can distinguish. It doesn't tell you if it's Parkinson's or not. It tells you if it's a Parkinson's versus Parkinsonism or a central tremor. So there are patients that have early, features of both, and you watch them for a little while. You're not sure what's going on, and you may want to get a DAT scan. So that's not that common that we do it. There's a very complex mechanism between Parkinson's, and there could be a whole lecture regarding that. So in general, it's not just dopamine, it's acetylcholine and other neurotransmitters that are involved. And it's a relationship between the basal ganglia, the substantia nigra, and other parts of the nervous system, even the brainstem. So we know that there's neurodegeneration, and this degeneration, the loss of neurons, occurs way before they actually get diagnosed and have symptoms. So 60 to 80% of the dopamine neurons are actually gone or diseased by the time they actually have symptoms. And so this affects both the direct and the indirect pathway. You've seen these pictures. This is just normal substantia nigra in the brainstem, and then you can see basically on the one side the loss of those neurons. And this is also a PET scan, so we're showing you a nuclear scan, and we're seeing decrease in striatal uptake. So in this scan on the left, the high uptake is nice and white and even red, and you can see the areas basically in the basal ganglion, and on the right side there's decreased uptake. It's not profound in this situation, but it will be over time. So what do? Right now we don't have anything that we know necessarily can help patients long-term with changing the disease process. We'll talk about a couple of medications that may help somewhat, but we control symptoms. So we treat those symptoms. We treat their tremor if it's bothersome, their slowness, their incoordination, problems with their stiffness, and also their gait. The problems with gait stability are probably the most difficult to treat because medications just don't respond really well to it. We can treat their dystonia, we can treat their sialorrhea also, and those things that they have. We can treat their dementia if they have that also. We also want to use treatment and avoid things that are going to cause long-term problems. So these medications, I just want to go over them briefly and talk about each of them. So carbidopa-levodopa, there are different formulations. There are short-acting, there's long-acting. There are different formulations I'll talk about in a second for their new exciting formulations. Most neurologists, at least the way I trained, we use immediate release. We don't like the controlled release for the most part because the gut is not normal in Parkinson's patients. You may have action of the gut moving quickly at one point, unrelated to a food meal, and other times it's slow. So we don't get we like to use the medication more often and get that drug in to get more consistency, but patients are always going to get poor or inconsistent absorption. As a rule, most neurologists will typically use carbidopa-levodopa after a certain age because we know it starts to wear off its effect, and you can have side effects like dyskinesia and shorter response within 5 to 10 years. So my general rule is if they're over 75, they definitely get Sinemet first. 70, 75 usually, depending on their health. And if they're under 65 or so, I almost always start with the dopamine agonist. And that's because if I start with them, let's say they're 60 and they have a lot of life to go, by the time they're 65, 67, they're going to have a lot of other problems from Sinemet. Now, that's not to say that if a patient's already advanced, I'm not going to start that medication, even if they're younger, or to start a dopamine agonist, titrate up really quickly, and then add Sinemet after that. Remember, I told my patients in general, since dopamine is the major problem that we can treat, I either give you dopamine, which is Sinemet, I give you a medication that works like dopamine, which is an agonist, or I make the dopamine last longer. So Mirapex and Requip are the most common medications that we use. They're dopamine agonists, and there's also Nupro patch. Nupro patch doesn't really go up high enough to the level of doses we want to get to. It's up to 8 milligrams. The doses are not equal, but Requip we may use up to 12 to 14 to 18 to 24 milligrams, which seems like a huge dose because in restless legs you use 0.25 and 0.5 milligrams. If you don't use an ER, it is a 3 times a day medication, so it needs to be given at least 2 times a day, preferably 3. I won't go over the side effects because you know what they are for those. So COMT inhibitors and MAO-B inhibitors are obviously making the dopamine last longer. COMT inhibitors have lost their favor a little bit, and they can help when dopamine's around. And MAO-B inhibitors can also reduce the breakdown. Now, there are some data that suggest selegiline, and even more so than Azilect, can actually be protective, but the data is not great. And the only 2 medications that we think that may be protective of the disease, besides caffeine and nicotine. Anticholinergic are great for problems with tremor, but they cause so many side effects, and I rarely use them because artane trihexylphenidate is fantastic for tremor, but it causes constipation, difficulty urination, and of course, problems with function and thinking. So not a great choice. And I've had patients that have had Parkinson's, have been on it from another doctor. They've done great. And then next thing they know, they start having mental status changes. They've had less hallucinations. I had a patient a couple weeks ago. I said, okay, we're going to check your urine. Urine was clean. Take you off the artane, and bam, she just cleared up. And amantadine, we use it in MS patients for problems with fatigue. We don't know why it works. And it tends to be sort of for one patient, they help the tremor. Other patient, it helps the rigidity and their stiffness. Remember, it's renal excreted, so you got to watch out if there's having renal insufficiency, and we just don't know how it works. So what are other options and future options? So deep brain stimulation, obviously, if a patient's maxed out, typically they're taking 1,000 milligrams of Cinemet or more before they go to DBS, plus they're on dopamine agonists, plus they're on Azilect. And they can help with rigidity, slowness, problems with the tremor. They don't typically help with postural stability. But patient has to be really up for it. They have to be have mental capacity. They have to have patients that can help, family members that can help them. So there are a lot of requirements psychologically and functionally that they have to have before they can get a DBS. And it doesn't mean that they're not on medications. It's not a cure-all, but they can improve significantly. The biggest thing that's really exciting that we see in our practice is the Duopa pump or the sub-Q dopamine pump. So Duopa is a pump. If you're not familiar with it, it is dopamine. It is Cinemet essentially. It goes in the gut as a PEG tube, and it gives them continuous flow for 16 hours. You can use it off-label for up to 24 hours. But I've had patients that just because they're on large doses, 1,000, 1,200, 14 milligrams of Cinemet, and they're on and off. They're maybe even in wheelchairs because when they're off, they're off. They don't get, their absorption is terrible. We put them on these pumps and they do really extremely well. The patients don't like the idea because they have a tube sometimes, but they have a lot of caretaker needs with the pump, but they can do really, really well. And there is an option besides DBS, and some patients they even have both. So I'm going to put a plug for this for sub-Q dopamine. There's no sub-Q dopamine that's approved by the FDA right now, but we're actually doing a trial where one of the companies that actually makes Duopa, and we're enrolling patients, and they have to have had at least 2.5 hours of off time, so they're not maximizing function. And if they meet that criteria and they've got idiopathic heart disease, then they will get put in a trial that we're doing right now through the company. There's only 2 sites in Ohio. The other one's Ohio State. And where they're either going to get their Cinemet, the regular dose of Cinemet, and the placebo pump, or placebo Cinemet and the pump. And there'll be an open label trial afterwards where they're actually able to get the drug no matter what, even if they were in the trial. So we're really excited about that. We will hopefully get even better continuous effect in the sub-Q pump that's actually continuous, and patients can unclip and everything else like that, and just have a little port in their belly and their stomach. So there are some potential disease modifying agents. Monoclonal antibodies are really big in the migraine world, the MS world, and there are potential monoclonal antibodies attacking the actual abnormal proteins in the cells that may be active. Gene therapy and stem cell therapy just it hasn't come out yet. We just haven't found it to the point where we're actually talking about it therapeutically. Of course, there's a lot of trials on it, especially in mice and animals. So in summary, Parkinson's disease is obviously diagnosed by symptoms and exam. Neurologic examination is very important. There's a lot of subtleties, and we can ask to talk about those. So dopamine depletion is what we can treat. We want to treat the patient while avoiding side effects and not making them worse, obviously. That's it. I'm going to stop sharing so I can bring this up. Questions, Heather?
Sorry, still muted. When
That's
do you
okay.
stop these patients from driving?
When do I stop them when driving? So that is a great question, and it's a difficult question. So it depends on how slow they're moving, but I will talk about it as early as I make the diagnosis commonly, and I'll ask them and their caretaker. More difficult nowadays because we're not having everybody come in the office, and I'll assess their reaction time. So if they're walking, there's no hard and fast answer. But if their fingertips are like this, its chances are that the reaction time is very slow. If they're able to walk 25 feet in less than 8 seconds, it's hard for me to press to suggest they shouldn't drive. If it's 10, 12, 15 seconds, they're moving very slowly. And the second thing is, you can do an objective test, and OSU has an evaluation where they can actually test people to see if they are able to drive. A lot of times we'll talk about not driving except for short distances at first and then stopping driving at first. I also ask if they've had accidents and use that as an excuse to stop driving. But sometimes we have to, really be aggressive and say, listen, you can't drive, and people are not happy about that, especially if it's their independence. But we do have an objective test to do, which can be helpful. And they can redo those even every year. So listen, every year, every 2 years, every 6 months, if you want, I'm going to have you reassess to see if you can drive. Especially if there's these patients are obviously intact for the most part. They're able to make their decisions. So if you disagree wholeheartedly, you can say every 6 months we're going to retest your driving, and then we'll let you drive.
When do you fill out paperwork for disability?
I personally don't fill out paperwork for disability. Basically, I would, as mentioned in the last lecture, I would send somebody for a functional capacity examination or send my notes, and I defer them to that. And most of my patients, it's funny because Parkinson's patients don't want to be disabled. They want to work for the most part. And I can't remember last time anybody even asked, and they should have been asking previously. So I'll support them if they're not functioning well, but I don't typically do it myself.
How does one differentiate Lewy body dementia versus Parkinson's?
We're not very good at it, to be honest with you. I can tell you, generally speaking, as I mentioned before, when you have a patient that develops dementia within 2 years of tremor, or tremor and Parkinson's symptoms within 2 years of dementia, you always have to think about Lewy body. Patients with Lewy body look just like Parkinson's, and they can respond to Sitimet too. But patients with true Parkinson's disease should not really develop dementia until at least 8, 10, 12 years later, maybe 5 at the way earliest, unless you have a patient that comes in and you diagnose with Parkinson's disease, but then you realize they're already moderate to severe and they've had this disease for 5 years. So you have to really get a good history, because if you diagnose them at day one, and they say it's been going on for 2 years, and then you're like, no, well, that doesn't make sense. And then you find out from the loved one or something, 5 years ago they've had a problem, then you can say, okay, this is probably dementia related to Parkinson's disease. There's no really diagnostic test that we can do necessarily. It's a timing and a time-wise. It's also a response to Sitimet, because patients with Lewy body disease will tend to wane with the Sitimet effect, and that doesn't happen as much except for dyskinesias and things like that for patients with Parkinson's. There is one feature: patients with Lewy body disease will have hallucinations earlier, again, just with the dementia, and they may have these episodes where they're somewhat lucid and they become more confused earlier, and that doesn't usually happen with patients with Parkinson's early in the disease.
Do we have any additional questions? No? Thank you, Dr. Taylor.
All right, thank you.
So that concludes our webinar for this evening. I will be emailing you the attestation form, eval assessment forms for you to complete for your CME credit. Please return those documents as soon as possible so that I can submit to the AOA for credit. We will be scheduling our 2021 seminars early next year. So look for that information. The Ohio Osteopathic Foundation always sends out an e-blast on our next and upcoming seminars. So thank you very much. Have a great day and happy holidays.
Thank you all.